happen is we will separate those diseases. It's also a clue for you pathologists coming up in a second. So keep in mind, and there's a recent couple of papers that showed not uncommonly extranodal biopsies that have this type of phenotype are in fact gamma delta. And these seem to be more common in Asians. They're not associated frequently with enteropathy though. Here's a relatively uncommon disease that's in as a provisional. This is the primary cutaneous CD4, so-called small medium, very long name. Some people believe we shouldn't even be calling this malignant. These things are so indolent, they typically occur on the scalp, but at least the head and neck, they have a typical look to them and a typical phenotype, also the compliments of Ryan here. But some people think that they really shouldn't be treated with any aggressive treatment at all. Now here's a nasty disease, and I apologize to the young Cesarmans if they're here. She's showing them terrible pictures late at night. This was a case I saw recently in Vancouver, 32-year-old male with these things everywhere, including some that were breaking down like this. Very nasty disease, CD8 positive, and the characteristic phenotype that we see with this. So this is another provisional diagnosis, but a very aggressive disease. And now we come to almost the end. Case number 2 for Mexico City, 75-year-old Caucasian man, presents with abdominal pain, weight loss, and a small bowel perforation. So in dire straits, to say the least. They went in and made as you can see here, did a partial resection of the small bowel, and a diagnosis was made. He really was too frail to be treated, and so they basically palliated him, and unfortunately he died a month later. So there's the histology. And a couple of stains. Anybody want to make a diagnosis? I realize it's late and everybody wants to go have a drink. So somebody make a diagnosis quick. Sorry? Yeah, so very interesting. That's what I thought when I looked at it as well too. So here's the CD2 negative, 4 and 8. No, sorry, that's 5. I think I showed you 8, did I not? No, I didn't. And here again, I've got some more slides. CD7 clearly positive. Does that say 5? I can't read it from here. I think that's actually 8. No, it's not. You're right. Sorry. 5 characteristically negative. That makes more sense. 7 positive. CD8 positive. 56 positive. Here's the alpha beta, and there's the gamma delta. So as it turns out, this in the adjacent bowel, when one looked, one could find malignant-looking cells in the epithelium. But the changes of classic enteropathy with villus atrophy, et cetera, were not present. So, and the patient had no history of suggesting anything of celiac disease. So this is very much akin to the recent cases that John Chan has reported from Asia. This patient was an elderly Caucasian, but this has a classic phenotype of the so-called type 2 EDEL, CD5 negative, 8 positive, 56 positive, TIA1 positive. But if you look in the WHO, it doesn't say anything about gamma delta. But we now know there clearly is a subset of these cases that express gamma delta. And so the point that I was trying to make by this case is exactly what I said about subcutaneous paniculitic, hepatosplenic. We're going to realize that there are gamma delta subtypes within all these categories. We will likely separate them. And so here's some more EBV, importantly, so anyone who's a good pathologist would have known to do EBV to make sure this wasn't a gastrointestinal presentation of a nasal T and K. But you can see TIA1 positive and the other markers here. So this was in fact a type 2 EDEL that was not associated with enteropathy but was gamma delta subtype. So my very last slide here is just to summarize very quickly. These are uncommon but a very diverse group of diseases. They're more common in Mexico than they are in Vancouver, where they only represent about 10 to 12% of all lymphomas. But very importantly, their distinction from B-cell lymphomas is critical, and that is because there are treatment implications implied by those diagnoses. That said, the classification is an ever-evolving process, and by the time the next WHO comes out in 2013, 2014, they'll be all completely different than what you've all been learning and studying, and absolutely without doubt, next generation sequencing is going to provide all of the fundamental insight into the biology of these tumors, and I hope that if I come back to Mexico City and sometime in the future, we'll be able to talk about all of our wonderful achievements in curing now some of these patients when we haven't been doing a very good job to date. I thank you for your attention, and if time, I'm sure, does not allow, I'm happy to answer any questions, so thank you.
Si pueden pasar, por favor, todos los que participaron para la mesa redonda para hacer preguntas. What do you call next generation sequencing? What do you mean by that?
Okay. Oh, I don't have a...
Here.
So, very good question. So what I mean by that is that I'll be giving a talk at USCAP, and I've given quite a few talks about that. The field of genomics underwent a revolution. And I equate that revolution to the introduction of the microscope in the 1850s. The impact on medicine and pathology is that profound, I think. And what happened is that the first iteration of the reference genome, one genome, took 15 years, took $3 billion US from 20 international sequencing centers to produce one genome. In about 2005, 2006, everything changed. And Illumina and Life Technologies have announced about 3 weeks ago that by the middle of 2012, they're introducing two new instruments, one called the Ion Photon, one called the HiSeq 2500, that'll produce 40x coverage of a genome in 24 hours. That's what's changed. So we have been sequencing cancer genomes, lymphoma, for 3 or 4 years now. And we've sequenced 200 or 300 cases, and some of you may have seen those publications. They are revolutionizing the field. It is absolutely unbelievable how much information is in these genomes. And by a combination of genomes, transcriptomes, and other approaches, we've discovered all kinds of recurrent mutations. We've opened up whole new fields of biology, histone modification. I mean, did anybody know that histone modification had anything to do with DLBCL and follicular lymphoma 3 years ago? Not a clue. And yet it's highly recurrent in those tumors. Some of those alterations, those recurrent genetic alterations, could potentially be targeted now, because we actually have HDAC inhibitors and things on the shelf that have been tried in CTCL and other diseases. We never thought to treat DLBCL. But if we now take the cases that have recurrent mutations and offer them therapies that make sense, we could change the landscape completely. So that's what I mean by it's Illumina, there's a whole series of instruments that are out there. They're all competing very much with each other. And the cost of genomes, I can tell you that we used to do a genome for $20,000. I just told you that the first reference genome cost $3 billion with the old technology, $3 billion. I can now, Illumina and Life Technologies is predicting those 24-hour genomes, by the way, $1,000. To get a whole genome at 40x, $1,000. That's all. You can tell I get a little excited when I talk about genomes.
Another question that has to do with the same topic. This morning you talked about Hodgkin's disease and a 21 gene chip, or can you talk about that?
That's good, and you weren't even there.
I know, but you sent the talk to me. I saw it.
I did. I sent you the PDF. She's selling them afterwards, by the way. She has PDFs of both the T-cell and the Hodgkin talk. So the Hodgkin study that some people were at this morning is I mean, again, I don't want to, it's not the theme of tonight, but suffice it to say we're about to submit to New England probably the beginning of next week. And what we did is we did gene expression using what's called a low-density platform. So not the typical Affymetrix array with 54,000 probe sets, but actually a very limited one. And we did all this work from formalin-fixed material. So we used the frozen material we had to discover, and we published that in New England Journal in 2010. And so we discovered all kinds of things. But what we wanted to do was to introduce a biological predictor that could help you as a clinician and others in the room make decisions up front about how to treat advanced stage Hodgkin lymphoma. And so what we did is we used a randomized phase 3 clinical trial. We extracted RNA from the formalin blocks, and we built a model by inputting 260 genes using a technology called nanostring. So those of you who are interested, nanostring is unbelievably robust. It is perfectly suited to the short type of messenger RNAs you get in formalin-fixed material. And so we did that to train, and from the 260 genes, we found 23